All right, let's talk about something we see in the operating room every single day. A patient comes in for surgery, and on their chart, you see they're taking an antidepressant. It seems routine, right? But the interaction between these common medications and anesthesia can be incredibly risky. So we're going to break down exactly what you need to know to navigate this safely.
So let's just get right to it. A patient on, say, an SSRI who needs an operation, what is the actual risk we're dealing with here? It turns out these medications can have some profound, even life-threatening effects on how a patient responds to anesthesia. So let's unpack that. Okay, here's our game plan. First, we'll cover the basics of why these drugs and anesthesia interact. Then, we'll go through the 5 main classes. Don't worry, I have a simple trick for that. We'll look at the older, high-risk drugs, then the newer ones we see all the time. After that, we'll tackle the biggest danger, serotonin syndrome. And finally, we'll wrap it all up with the critical takeaway. So, why is this such a big deal? Well, it all comes down to neurotransmitters. You see, antidepressants work by changing the balance of chemicals in the brain, like serotonin and norepinephrine. But here's the thing. Those exact same chemicals are also crucial for controlling your heart rate, your blood pressure, basically your whole stress response. And what do we do in anesthesia? We manipulate those exact same systems. So you can see how things could get messy fast. Now, I know what you might be thinking. There are dozens and dozens of antidepressants out there. It feels totally overwhelming. But here's the good news. They all basically fall into 5 main categories based on how they work. If you can get your head around these 5 groups, you've cracked the code. And to make it even simpler, you just need to remember this one phrase. Many sad souls take therapy. Seriously, that's it. Each word gives you the first letter of a drug class. MAOIs, SSRIs, SNRIs, TCAs, and the atypicals, which are also called TCAs. This little mnemonic is a lifesaver for keeping everything organized. Let's start with what I call the old guard. These are the tricyclics, or TCAs, and the monoamine oxidase inhibitors, or MAOIs. These were some of the first antidepressants ever made, and while they can work, they're kind of like a blunt instrument. Their mechanism isn't very targeted, which means they come with a whole lot of side effects and really dangerous interactions. Okay, so check this out. TCAs use what you might call a shotgun approach. Sure, they hit their main target. They stop the reuptake of noradrenaline and serotonin, but look at all that collateral damage. They also block a bunch of other receptors. And that is exactly why you get all those classic side effects: sedation, dizziness, dry mouth, and, most worrying for us, serious changes to the heart's electrical rhythm. And this brings us to probably the single most important point for anesthesia when it comes to TCAs. If your patient's blood pressure drops during surgery, which happens all the time, the drug you choose to bring it back up is absolutely 100% critical. If you pick the wrong one, you could be headed for a disaster. This chart just lays it out perfectly. Look at the TCA row. If you give an indirect-acting drug like ephedrine, you're going to get a massive, out-of-control spike in blood pressure, so you have to avoid it. Instead, you reach for a direct-acting agent like phenylephrine. But even then, you've got to use a smaller dose because the patient's system is already primed. And, well, as you can see, for MAOIs, the situation is even more extreme. And let's just be crystal clear about this. When we're talking about MAOIs, we are talking about absolute, non-negotiable contraindications. These interactions aren't just bad, they're some of the most dangerous in all of medicine. And here they are. Pethidine and tramadol are completely off the table. Forbidden. Giving either one to a patient on an MAOI can set off a catastrophic chain reaction. We're talking a raging fever, seizures, and a total collapse of the cardiovascular system. It can be fatal. And just like we saw in the chart, indirect agents like ephedrine are also a huge no-go, risking a hypertensive crisis that could kill your patient. Okay, so let's shift gears and talk about the new guard. This group includes the SSRIs, SNRIs, and the atypical antidepressants. These are the ones you see prescribed far more often today. They're much more selective in how they work, which is a good thing, but that doesn't mean they're risk-free. They just bring a different set of challenges to the operating room. The mechanism here is much more of a sniper rifle than a shotgun. They're designed to selectively block the reuptake of just serotonin, or both serotonin and norepinephrine. The great thing about that is you avoid a lot of those harsh TCA side effects. But, and it's a big but, they introduce 3 new major risks we have to worry about: a higher risk of bleeding, major interactions with other drugs because of how they affect liver enzymes, and, once again, a high risk of causing serotonin syndrome. And then we have the atypicals. These guys work a little differently. Instead of blocking a pump, they basically block the brake pedal on the nerve cell.
By blocking that brake, they cause more noradrenaline and serotonin to be released. For us, the bottom line is that while they're cleaner than TCAs, you still have to be on the lookout for sedation and those really tricky drug interactions through the liver's CYP450 system. Now we've reached what is arguably the single most important danger that connects almost all of these different antidepressants. It doesn't matter if it's an old MAOI or a brand new SSRI. The potential to trigger serotonin syndrome is the one unifying, life-threatening risk that we absolutely have to prevent. So what is it exactly? Well, to put it simply, it's a toxic overdose of serotonin in the nervous system. Think of it like a serotonin storm. And it almost always happens when you combine two or more drugs that both increase serotonin levels, like giving a certain pain medication to a patient who is already taking an SSRI. So how do you spot it? You look for this classic clinical triad. First, their mental state changes. They get confused, agitated. Second, their autonomic system goes haywire. Their temperature shoots up, their heart races, their blood pressure is all over the place. And third, their muscles get hyperactive. You'll see twitching, rigidity, and overactive reflexes. And please pay very close attention to those common triggers at the bottom. Things like methylene blue or the antibiotic linezolid are used all the time in the hospital, and they can be the final straw that pushes a patient into this dangerous state. Okay, so let's bring it all home. We started by asking a simple question. When a patient on antidepressants needs surgery, what's the real risk? Well, the real risk is that all of these things can happen. This is why knowing that medication history is absolutely non-negotiable. You need to know which drug they're on so you can choose the right vasopressor if their blood pressure tanks. You need it to avoid a fatal drug combination. You need it so you're ready for extra bleeding, so you can spot serotonin syndrome before it gets out of control, and so you can predict how all the other anesthetic drugs you're giving are going to behave. It touches literally every single part of what we do. And that really leaves us with one final crucial thought. This isn't just about knowing pharmacology, it's about talking to our patients. A careful, thorough medication history is our #1 line of defense. So the question I'll leave you with is this. Are our pre-op interviews and our clinic assessments truly set up to catch this vital information every single time?